I'd like to flag two paragraphs in the introduction to the last chapter, which sort of gives a background of where I come from on this. Because one of the questions that you have also posed is, as public health professionals, or even as public health researchers, what real space do you have in changing policy? Policy makers are often made by politicians, and politicians and their access and their drivers are very different, and even bureaucrats are very different to them. But the primary inspiration for this book is to make an impression on policy, is to change practice, is to shape policy. It's not meant as a book which is purely at an academic bent. It's meant to inform not only academicians, but even more so people who are in making policy. So there is therefore this initial caveat that I put in place. So I'm reading now. One expects that when faced with the problem, general administrators would consult domain professionals to diagnose what causes it and suggest remedies. Unfortunately, this is seldom the case. More often, administrators already have strong ideas about what the problem is and how it can be solved. They just want to run it past experts to see what the expert has to say and tweak their plans accordingly. Those with less insight and more pride, and we have a lot of them, may only be seeking applause. On the other hand, leaders with a more reflective and scientific temperament may want the professional to pick holes or weaknesses in their plans so that they can have another perspective on the problem and see the problem with fresh eyes. They want a sparring partner, not a yes man. Either way, the professional needs to learn not to make too much of their invitation to the decision-making table and recognize that their opinion only adds one voice into the pool. If it is only a matter of opinion, authority prevails. But if professionals also brings evidence to their table, their voice is so much the stronger. Authority itself has more than one source. Authority could be based on hierarchy, could be based on control over finances, on relations and network support, or not the least, knowledge too generates authority. So I'm very often invited, and I'm speaking now out of the court, to lot of committees, whether it's joint monitoring missions or disease-specific programs, whether it is almost any major policy committee which has been formally constituted from the government from, I think, about 2005 till today, till recently. Even today, not in all the committees, most of them, one gets a place to be there on the table. And one must use that space very creatively. And I'm very often disappointed by others who come and say, what's the point of speaking? Nobody is going to listen. The decision is already made. When actually there is a lot that one can do. One major difference, I'm now quoting again, between commercial consultancies who have an increasing and overpowering role in modern public health decision making and the public health professional and academic is that the former is too client driven, far too eager to find a justification for a decision that is already indicated. In contrast, the spirit of academics and its prime duty is to speak truth to power. And if there is not such space within governments, there is always the opportunity to engage outside to shape the public discourse. This is a concept that we keep moving. The public health community and public discourse are two concepts that I build on this. This could present methodological problems for policy and systems research, which requires consultation with key informants, and their subjective views are part of the method. Often you have to interview the secretary and the board to find out what they think about it. But then, a guiding ethical principle that could help the policy research is that the structure of research shall not be geared towards producing the desired outcome for its client. With these caveats in place, let us take a closer look at the sources of knowledge for health policy systems research and some important methods that are illustrative of the science. I close here now. So this is actually very well fits in with what you are doing, building a learning system. And the closing chapter is building learning adaptive systems, knowledge management in the 21st century. And since my audience is actually my primary target audience are people with medical backgrounds who are willy-nilly performing public health leadership roles at the district and state level. Almost everybody in the directorates of public health are within this, and they have never been introduced to it. Many of them were, in fact, even when I was writing this book with students and others discussing, they said, we have never heard of these. So we have discussed a few tools of health systems research. I know why I'm making it elaborate to say it. For you, this must be passé. I mean, this is something that you're almost born with knowing. But for the audience that I'm saying, these tools, even the case study, even realist evaluation, even health technology assessments, institutional analysis and development. Just to give an introduction that this is its own discipline, which has its own rigor, but yet it has all the rigors of a positive science, but it is also full of political contestations where ideologies, power matter. And that's exactly the way in which we have framed this. So I'll just take 2 more minutes and I now go to the introduction to section 3. So this is the background of where this is built up. So I say in the first section, which was on the basic understanding of public health, we made some important submissions. First, that public health practitioners and professionals must engage with the structural, societal, and proximate social determinants of health, and action on these determinants would probably contribute more to health outcomes than medical care. We also posited that while medical care for an individual would be the prerogative of the clinician, the organization of medical services for a population such that everyone has access to quality care with financial protection for all their healthcare needs is very much the responsibility of the public health practitioner and public health science. Sometimes this word public health is used only in terms of non-medical care. And that the organization of services is, but yet you have to differentiate it from what clinical care is and what a hospital administrator does. Again, I'm saying this because I'm largely writing to people who come from that background and have to know. So one of the common things we teach is that a hospital manager feels responsible for everybody who walks into the hospital. But a public health manager feels responsible for everybody who walked in, but even more so for those who did not come, even though they needed care. That informs this. In the second section, so this book has 3 equal sections. We are talking of second sections. We made 2 important submissions. First, an approach to organizing public health services based on a selective approach, where we begin with a few health conditions and then incrementally add on more, is neither essential nor efficient. The selective approach also goes against health equity and health rights as it leaves the majority of healthcare needs of the population exposed to the high costs and questionable quality of market-based services. This is a fundamental positioning that we are making. It's important even when the new Lancet Commission is there, just expanding the selective package. And this is discussed at greater length why that particular thing does not work. And second, hoping to eliminate communicable disease through improved technologies without attention to the social determinants or to health system strengthening is also a fantasy, as it is unlikely to succeed for most diseases. We have in the earlier section 2 looked at tuberculosis. The very many times that people have said that they will eliminate the disease and where they are at the end of the thing actually facing increases, and also many other issues of that. We'll completely look at that particular angle. So this is the first 2 sections. So the second section has been definitely going on disease specific things, because the most of the people I work with are working in an HIV program or TB program or in charge of a leprosy program, and to talk to them about health system strengthening seems outside their canon band. So therefore, it goes to that. So now I'm just getting to 2 paragraphs and then I'll stop. There are many ways in which the discourse around health policy and health systems has been framed. The dominant approach for long was New Public Management, NPM. A collateral of neoliberal thinking, it held that while for some public services, for some were to remain public, their efficiency could be reformed by subjecting them to market competition, introducing prices and cost recovery, and many types of monetary and non-monetary incentives. This dominates thinking about health sector reform. This was replacing the older, more traditional public administration approaches, which focused on organizational strategies within the administrative domain. To us, the important point of departure, the a priori commitment, if we may say so, is to achieve policies and systems that would ensure that health and healthcare are public goods, and they should be available to all, irrespective of their ability to pay for it. So there is a goal, and that's what our methods flow from that purpose. Our point of reference is not the academic literature on health policy and systems. We do not begin with a review of the literature and build on it. Rather, we only draw on it where convenient. And I like Kabir's response to this. Rather, we only draw on it where convenient to help us analyze a case study or support our contention. Our main point of reference is contemporary public health practice and the problems, or rather problematics, on health system strengthening it is engaged with, and how policy making proceeds in the real world. Administrators and policymakers pressed to find solutions draw upon different approaches, not necessarily conscious or heeding of their theoretical underpinning. And in the absence of any grand theory equivalent to new public management and health sector reform, practitioners of health system strengthening rely more on best practices and case studies to learn from. But a best practice based empiricism has its own limitations. There is a need to develop better frameworks of analysis, develop more productive research tools, and propose theoretical understandings that can guide practice. And for doing so, we are drawing as much from lived experience and discussion with peers as from publications. Most of our case studies and examples are from India. This, in our view, is a necessary phase. We cannot venture into new theorization without a density of empirical observations. And such a density would need to be related to the context that the authors are most familiar with. India offers an exceptional site for such observations. It is large, it has considerable heterogeneity in development, diversity in cultures, and contestations in polity to generate an inexhaustible source of case studies and interpretations. Though each country would have its own context and path dependence, the main principles that we articulate in this book would have much wider relevance across developing countries. There is a sort of anticipatory bail that I am taking on many of the objections that can be written to the way that we have written upon this. But this framing of it in terms of different problematics that we are addressing, and each problematic, taking from the French problématique of Foucault, is basically a problem that doesn't go away. It continues to persist across times, spaces, and admits of different answers in different contexts and even with different ideologies. So I remember we were working on one time on how do you attract doctors to stay in rural and remote areas. Or how do you look at transfers and postings policy within that? I think you did a Bellagio workshop on that in this. Or we have done a number of these things which we have done. It's just that I've written it up in my own way. That is due. Kabir will possibly recognize a number of these things that we were engaged with problems. So in each one of them, we take a problematic end. So in financing, when we were writing this, there's so much to write. I mean, for most of health system strengthening is written around financing, and we had one chapter space. So we just took up one problematic. The problematic was, if we are already certain that we have to offer financial protection, why we need to offer financial protection is in chapter 4, the political economy of healthcare. But if we have already made a decision that we should provide care free or affordable to everybody, irrespective of whether they are poor or rich, what are the approaches to guaranteeing it and the pros and cons of each approaches? That's the only thing that we are handling. And when you're talking of public health financing, then of course you have to talk of the adequacy of financing. So we just take that particular point. It's not an overview of the different payment methods. So I was getting lost to different ways of payment, different ways of thing. Yes, there is a lot to be said in that. But eventually, when we were practicing it, we never encountered that. We encountered the debate in what delivers financial protection. And that's an important debate because if you see after 15 years of implementing universal health coverage, the WHO's latest reports concede that actually financial protection did not occur and actually worsened. They are changing the system of measuring it. That may change. But if you go by the trend on it, financial protection has worsened. And we need an answer, then we need to look at what does it mean, and it needs to take the discussion beyond insurance and purchasing. And therefore, we need to bring back the older social insurance system, which we bring back with the ESI system. Why that didn't deliver, and then the PMJAY, the contemporary publicly funded health insurance system, and then the public-private partnerships, and then come last to public provisioning and public financing and why it does that. That's the financing chapter. The organization of similarly in public health informatics. It is no longer the solution to the problem. What? Digitization. Digitization very often is the problem. It is so much of a burden of additional work that peripheral providers are doing that it is costing on patient care and follow-up. It's actually taking costs. In fact, one of the big barriers to the addition of new from selective care to comprehensive care, of integrated care is, if you say one more disease to add on, there will be a huge resistance simply because it means so many forms more to fill, so many more apps to fill on, so many more things. Not because the patient you're going to the house, the other patient is in the house, you can easily manage that. Making a visit to a house, to managing diabetes, hypertension, if you also have to look for elderly care, it's the same visit. But if it means that I have to have another app for elderly care, another full form for another register to be maintained, and I make this visit one day for NCD and another visit another day for elderly care, and it's just too much burden of work. So that integrated care which you are dealing with at some point is efficient, provided you don't have these absurdities and nobody notes it. So when I wrote this chapter, the students who were helping me with this, the postgraduate students, so sometimes I had to present this chapter to a class for me to get my head around what I wanted to say and what. So they were very cooperative. They would assemble 30, 40 students and I would take class for them and get them down. So when they read this chapter, their first response was that, sir, all this is really true, but we never thought that it could be part of writing a paper or a book. That was outside. And the response that most of my students get when they go to the field is, sir, what we see in the field is like nothing like what you're teaching in class. And what is happening in the field is never captured in the substance of a book. The book is a normative description. Public health informatics will talk about flow of information, about management of information, artificial intelligence, but it will talk about flow of information. It will talk about structures of information. It will talk about things, but it won't talk about all these things. Somewhere do not enter the text. And what we've tried to do in public health informatics is engage with the problem as it is formed. That's a problematic. So we have designed the problematic. One problematic is of why, when we collect so much data, people use data so poorly. You waste so much time collecting so much data, nobody even sees much of the data. Or another problem is everybody says that we have too many systems which are interoperable and going. But no sooner have you said it, at the same year they are introducing more systems. And now we have run away. We've just lost it. We've got so many apps and systems in place everywhere. So why is this problem there? If it was only in one place, it's all right. In another place, and another place, and another place. What are these common problems that we face? Privacy, confidentiality is one part of the problem, but there are electronic health records. Everybody swears by it. For everybody, it's the golden solution, but it doesn't have, actually hasn't happened. And that electronic health records has led to better health outcomes. Which is not to say we don't want electronic health records, or that digitization will not help, or that it has not helped. It's just that we need to engage with the problems where they are. And this whole health system strengthening is basically framed around this idea of understanding problems, trying to understand some basic principles, and they do relate to larger structural principles of that. So there is one section on health policy and governance, where the problems we are talking in governance are federalism, decentralization, the conflict between the technical and the administrative, between the Directorate of Health and the General Administrator, and about institution design and capacities, why various institutions don't perform, whereas similar like Tamil Nadu has a very good procurement system. When you try to replicate it in other states, it doesn't work in most states. So what happens on institutions? So we've looked at health policy and governance with this as these four problematics. That doesn't mean there aren't other problems. But we are trying to say these are what we find as the central problems to strengthening public services. And framing it different from saying you can outsource it or have a partnership and it will solve the problem. We don't think it has solved the problem or will solve the problem, but it definitely you have to think about it in a different structure to understand how that problematic can be addressed. And some of these problems are problems that have really not been taken up as central. Yet, if you're talking of strengthening public health service, okay, it's one thing to say, don't privatize. But then how do you make public systems work with that degree of efficiency and accountability? How do you give an answer to that question that you must make it work with accountability and reliability without resorting to privatization or private incentives? Because that's not only an ideological position, but self-confessed thing, but also because that also hasn't worked. So how do we look at that? That's how we have framed this book on that. This is a book meant to be transacted. I've already done part 3 as a 5-day session. 6 hours per day allows people to 2 hours of classes, and then they work around it with a problem that they know, and they take up a problematic and they present on this. But we are constructing, even in the first 3 things, this could be covered as an integrated code. This is also very useful for people who are not going to do public health, but need an understanding of public health. They are working in some other related area, but they need an introduction to public health. This is also an audience for this. So I hope basically useful. I would look to a critical feedback from you all on this. This book will be taken across our own spirit. I come from a very activist background, for those who don't know me. We take 1 year to write the book and 2 years to make people read it. So it will be there, not necessarily because the market will do it. We never believe in markets, but we have already structured a number of transactional training programs or study programs. The Directorate of Public Health in Tamil Nadu is taking it up. The different schools of public health, we hopefully will provide a space to transact this at a regular basis. So hope it helps. And it will also help you to frame your research, hopefully, at least to think about it.
We have some dialogue. People online. Do you have some time?
Yeah, I have time.
We have people online as well.
Yeah, please.
Can have questions as well. So maybe I'll just kick us off with one, and actually it might.
Kabir, you'll recognize a lot of things I'm saying. These are old arguments that we have held in discussions.
People online, can you hear me? Can you just nod if you can?
We can.
Okay. Thank you. Actually, yeah, Dr. Sundar, we come from a. I mean, you of course preceded my work in public health, but we have a similar lexicon, I think, in many ways, because we studied the similar issues and a similar way of approaching things. But one of the things that really interested me in what you said was, what is the domain in which this health system's work functions? And obviously, it's not one domain, it's multiple overlapping domains. And we ourselves because most of us are at the Global Business School for Health, we sit within a population health faculty. So this issue of disciplinary boundaries is quite important. So our immediate context is not public health, it's actually management studies. And then with a broader context is population health. But we'll probably distribute this talk as well so that other people could come in and comment. But one of the initiatives we've recently started is a new master's program in health systems policy and innovation. And Maika Schleif is going to be leading that, and she's on the call right now. So we've really been delving in with this question as to what is the audience for scholarship and thought on health systems. In some ways, the people we get to who will attend this course will answer that question for us. Are they going to be public health practitioners? Are they going to be people in different sectors who are interested? Are they, as I said, essentially a liminal kind of a discipline or a field. And I'm sure Maika might have something else to add to that, but I just wondered if there's some reflection on what constitutes a health systems practitioner and what constitutes a health systems scholar. Because clearly there is a need for more scholarship and a need for more understanding of these issues. But what is the audience that can drive this need?
Yeah. A new batch of students coming in, one has to think of it differently from so-called, like I'm taking a parallel from general education, adult learners. When people who are already experienced or practicing within the government or within consultancy organizations or within resource centers, you can and you do willy-nilly enter health systems from many sources. So you have some people coming from health economics, which is a big stream now. A lot of people still come in from clinical medicine. They have been practitioners and sometimes they have become administrators, and sometimes because they have reached a certain seniority have got into it. They therefore enter the topic where they find it. And when I'm in even the conversations talking with a number of clinicians, I find them very good. And we had this problem in COVID-19, for example, when you had some leading virologist or disease specialist, infectious disease specialist, they get something so right and they get something so wrong. And the things they get wrong are the interface with the social sciences. The things they get right, the more biomedical it goes, the more positive it goes, virus, its transmission, its incubation period, it's this. Even if they don't know, they get there. But in social sciences, inequity with the same restrictive measure operate on different things. They really don't get there. So therefore, I think these people who are willy-nilly managers of this have to actually need compulsorily, obligate a grounding that makes them see the whole picture. Otherwise, they tend to see the elephant from where they encountered it. For a master student, and I know this now after teaching a lot of master students all over, and they are everywhere. If I look at my master students, they are everywhere. Some of them are in World Bank, some of them are in WHO, some of them are in teaching, some of them are leading departments, some of them are research associations. Many are working in the National Health Mission, I think. So you don't know where they will actually go. And very often their sense is that when we enter a job, we enter at a junior level. We are a cog in the wheel. how do we look at something as grand as policy that politicians do and hope to make an impact? There is a sense of helplessness if you enter and say you are entering in the tobacco control program in Madhya Pradesh. I have a student who is doing very good work there, or Jayalithya in Tamil Nadu. I think I must say my student actually, between you and me, give her the full credit for having built up their emergency system on that. But she came in, and nobody was listening to her. She was the GMO's consultant for fetch and carry, short of making her bring in the coffee, almost everything you will do. But yet, from that position, you must be able to exercise a philosophy of change. So, to be able to see that from whichever vantage point you are, whichever position you are given to stand, you can make a change. It may not be a big change, but you can have a comment. So you have to actually prepare them for multiple vantage points. And therefore, a good grounding on principles that allows them to see how it is. And some field immersion so that they know the reality of it. Whatever you do, despite this book, seeing it on the ground is important. I think will allow them to choose where they want to go. And for people, students, it's difficult because they are also limited by who will give them a job, who will actually find a thing. But they need to be prepared to be managing more than one type of situation. And at all times keep their intellect alive. Because there are many jobs that de-skill you. And the higher paying jobs tend to do it more. Like if you were a polio monitoring surveillance person with UNICEF, you would get the highest pay. But you just know to fill that particular polio surveillance form. At the end of 3 years, you've forgotten public health. Completely forgotten it. And therefore, I keep telling them, keep your breadth of vision going. Because you don't know where the solutions come from. It is interdisciplinary. So if you're locked into a job, then you will lose your public health skills. Any job, including a job within public health. Because public health needs to remain interdisciplinary. And by definition, when you do a job, you will be focused. So that's a challenge. But I think masters should prepare persons for a width of skills. Positions that they may occupy in life. You can be a practitioner, you can be in academics or in consultancies. Some element of consultancy is useful. It leads you to problem solving in a particular way, which in academics, you can raise a question and be there. But if you are engaged with that, you have to come out leading some recommendations. That sort of exposure, a consultancy like posting, teaching is also, these are the three skills: an implementation area, a consultancy area, a sort of researching position. Where you go will depend upon many things.
Thank you very much, professors. Thank you very much, professors.
Sundar.
Yes, sorry. So, you've given us a lot to think about, and it's very interesting. I know there's no right or wrong answer to this. Prior to starting, because I'm also a clinician with a clinical background, but then thinking more systems thinking. And I used to think maybe the best people in positions of influence in policy will be those who have a clinical background, because then they are more in tune with how they can be more equitable with all of this. But the more I interact with people, I understand the perspectives of social science as well. So maybe I wanted to just ask if it's much better to also include, you've talked about giving students an opportunity, but maybe including such a science in clinical practice as well can sort of broaden the options that are available for people who are studying clinical medicine, or maybe even reorient the way we think about clinical medicine towards a more systems perspective, and then we can have more people who are interacting with health system strengthening, even in their own little pockets. Just wanted to get your opinion on that.
There is a current course. It's called Preventive and Social Medicine. And we go in the main introduction to the book to differentiate why this is not that. The problem with that is it comes, whereas public health clinical medicine is a subset of public health as we understood it. Preventive and social medicine is a subset of clinical medicine. It need not be that way, and I think we should work to transform the teaching of that subject. It is now crammed too much with epidemiological details and too little with social understandings. Unfortunately, to develop a faculty within a medical college establishment that can teach social sciences has been very difficult. And to even give them that sort of stature and respect within a very hierarchical view, there is a whole tribal behavior there. So it has been a problem. But there's some very interesting examples that start with teaching of humanities and literature to medical students, which makes them appreciate better. So now Sri Lanka is planning to start up with one. There is some programs where, good literature gives you a vicarious experience so that they can imagine what the larger issues that we are talking about deprivation, about loss of care, about this and that. For example, one of the best things on human resources for health, and I wish sometime you screen this, it's available on Netflix now, is a movie called Late Shift. One in the Berlin Festival also it was screened. It's a recent movie. Such a brilliant exposition of what it means to be a nurse in a tertiary care hospital, and it's the whole problems, and it expresses it, which can't be done in any text. So once you open up to them this dimension of social science, then you may actually be able to show the necessity of tools to the standard clinician. And I'm a professor of internal medicine initially for 22 years of my life. So then only moved to, now it's 24 years that I've been in public health. So it's 22 plus 24, but first 22 was in clinical medicine. For us, the act of making a diagnosis is scientific. We need a lot of things we need, but everything else is common sense. I know a senior neurosurgeon who used to do that. I can understand discovery of drugs, but what is all this thing about mosquito control? How much research do you need to know how to swat a mosquito? The very famous neurosurgeon made this issue. They trivialize much public health knowledge into something that it is, and they act on it also. It's like glorified common sense to them, how you will manage doctors not coming to remote and rural areas. So it's their opinion that matters, and most often they concede it cannot be done. It's a sort of barrier. And when they hear for the first time that actually this is a problem that everybody faces and most people except you have solved it, then only they start recognizing that there is a science here, that there is a domain of knowledge here. The real problem with clinicians is make them accept that there is a domain here, a knowledge that has to be learned and taught and transacted, which has tools, which has methods, which has ways of doing things. So that's a problem of clinicians here. I sort of get away with saying it because I can then pull my professor of medicine back. If I was not that, they would not particularly agree on saying that.
Micah, Rodolfo, anyone wants to?
I have a comment.
Sure. Yeah, go ahead.
Yeah, first of all, thank you for the great presentation, Dr. Sundararaman. And it's not a question, as I said, it's a comment. I think you said something very important. You said, when we think about the digitalization of public health, many times we collect more and more data. But the truth is that collecting more data doesn't mean improvement. And actually, many times we don't have the time to look at that data. And just to say that, I saw these things across Europe as well, in Sweden, in the UK, in Italy, in Spain, and hospitals spending huge amounts of money, collecting more data variables, collecting more information, and then they don't do anything about it. And this has been like something really fascinating, especially now that we talk a lot about value-based healthcare. And they think that, we have a lot of data, but this does not translate in better outcome for patients. And I think that, your message is very important here. And I think that, the fact that, we don't have the time, or clinicians don't have the time to look at this data, really makes a huge difference.
I call this the use problematic, the use of data problematic. In the earlier book, I had a full chapter, long chapter on that data use problematic. Here, there's a Finnegan's law of information, like Parker's law principles, and there's a fun law which says that the data you want is not the data you need. The data you want is difficult to obtain, and finally the one that you can obtain is too costly to obtain. So the data you think, so none of it works out. So in some sense, yes, this is universal, and very few people recognize the universality of the problem. They would think it is their problem. In India, I would think it is a problem that my Indian managers are mixed up guys, and they are mixed up guys. So, and they've got it all messed up. But then when you start seeing a pattern which is cutting across boundaries and this, then you've encountered a problematic. And this notion of a problematic means that you have to look at different structures for solutions and admit that there are different solutions into this. I do not even begin to do this, but long back when I think I had Andy Haynes, who was then director of London School. He had come to NHSRC. This is the time before I wrote about it, when I was practicing. So we asked him this. We asked him all these issues that are health information. We had started our HMIS and it was not working. And he gave some very practical guidelines, which we are still followed on. So anyway, you must read the book. It's a full chapter on that. But yes, that is really it is a problem across. And most of the problems that I've dealt with are problems across the entire health systems. They are not, and they are not problems that have attracted much attention. Because you're not thinking of structuring public. You just say public systems is inefficient and you assume it is inefficient because they are public. Whereas if you give it to private, it will be efficient. And then our PPPs don't work because it's not about whether it is a publicly owned person or a privately owned person. It's how you've designed it. There are problems in the design. So if you give this designed product to that fellow to run, he is likely to make the same mistake. So between private and public, they'll end up having similar outcomes because the problem is elsewhere. The problem is not in the ownership, the problem is in the institutional design. So I think that larger sense of institutions.
Yeah, Micah, go ahead.
Excellent. Thank you. Thank you so much, Professor Sundar. So as Kabir mentioned, we're starting a new master's program this year, which we're very excited about. And one of the kind of core themes of the program is around innovation. So obviously coming from a business school, we've started with a sort of, well, we've recognized sort of how our students likely and other stakeholders might first perceive innovation, thinking primarily digital, whatever, but really starting to dig into that concept of what does innovation in health systems really look like. And from what you've described and from what I've seen from your book so far, you don't really pull it out as a separate topic. So could you comment a little bit on how you see sort of effective innovation from a health systems perspective, and how you might frame that for a student who's just coming into this space?
So, in my framing of the issue, this book is essentially about framing problems. It's about framing. So that's therefore a good question. I think that in each of these domains, you remember that WHO matrix of workforce management, organization of services, information technologies, governance, financing. Normally, when we look at that, each one of them becomes a rigid box of its own, and we talk of health systems, we divide it along that line. But when you take a problem, it all comes together. And normally, in each one of them, there are a number of problematics. Whenever you enter a problematic, you need an innovative solution. What is the alternative to an innovative solution? So it's a different way of posing it. If I were to ask, for example, what do you need to do for attracting people to work or improving the quality of care? In the classical public administration approach, you define the hierarchy and then you demand enforcement. Okay, quality is not there. You decide he is the person he'll report to, he is the monitoring person, and you make sure that monitoring is tightened and you enforce it. And digital tool will help in surveillance, and eventually it boils down to creating a structure of rules and then enforcement. So classically, it's an administrative hierarchy under which any health system, any problem admits of one framework which is then enforced. So it's enforcement, and most often it is enforcement of what already exists. So if you have transfers and posting, what you do, you make it compulsory. Otherwise, you fire them from the job. You lose them, and we can't be done. Or how do you do informatics? You may just make sure you have to do it by this. It's all disciplinary. Okay, because public comes with a notion of a state. In the South, we thought it was because it was the colonial inheritance we have. But when you have in Europe, the same problem is there with the colonizers also. We can't quite attribute it. But eventually, what it meant was the nature of the state. The state imposes a particular diktat and enforces it. So that's in alternative to it, we say, no, this is about state capacity. And state capacity, the ability to deliver on a particular thing depends upon institutional design and institutional capacity, and that's one way of it. The other, which came with the new public management, did use innovation, but innovation for largely making it less public and more like the market. Because this presumption is there that private sector has always got a greater capacity for innovation than public sector. Unfortunately, among all the complaints between public and private, I never agree with anyone except this one. It is necessarily true that the private market-based system tends to be more innovative. Innovation in public system has its own problems. Okay, and therefore, innovative solutions in institutional design are never your first choice. Your choices are enforcement or innovation in the private sector. Sometimes you say, I will contract the whole district health service to a private entity and then he will solve all the problems. How do you expect him to solve the problems? Because implicitly you think he will innovate. And of course, it doesn't work because of many other reasons. But the point is, he does innovate to make his profit higher, but not necessarily health outcome higher. So therefore, this innovation is not something that is a separate space. It is something that is innovative and creative design. You have systems innovations, you have programmatic innovations, you have innovations in it. And eventually it is, I'm understanding institution as the process of the rules, not just the structure, not an organization. So the rules in process, the norms, in that structure, you will need. So innovation is a constant thing. Question is, what are the conditions in a public service that will foster innovation? I don't think I've answered it fully in this book. That's something that we will have to reach on. The general point is that innovative solutions are required to problematics. Is there a method of innovation? There is no method, but what are the methods in use? How have people arrived at different solutions? What were the pathways through which innovation happened in public services? That we have not really addressed. I'm conscious of that, but that we try to develop case studies that show how it happened. because there's this iterative thing. Sometimes a cancellation of errors. You go one way, then you do another thing, and then you do another thing. That we have not captured. But the point that innovation is a sort of cross-cutting theme that whenever you encounter a problematic, think of what is the innovative way to solve it. The other rule is like this. If only 10% of the people have got it wrong and 90% have it right, maybe enforcement will work. But if this is a problem everywhere, then enforcement cannot be the solution. If use of information, for example, is a problem everywhere, then necessarily it's a design problem, not an enforcement issue, not even an incentivization issue. And you have to think about the problem with a larger structural lens. I mean, little two bits. I don't know how it works out in practice, but this is the way one discusses the issue. But that gives you a lot of scope, no? That means that you can take up any problem and be hopeful that you can come up with a solution within a given issue. You can look at best practices, you can look at positive deviations, you can look at what are the principles, why they work, and think of different things.
Absolutely. Yep. Really, really helpful. Thank you. And thank you for kind of framing in a clear but also a bit flexible, as in, as you said, there's room to work in the spaces of sort of what the public sector looks like, what the private sector looks like. Thank you. Really helpful.
There's this Schumpeter, have you heard of that? And he believes that the great advantage that capitalism has is in innovation. There's a political economy stream which looks at innovation as the central to this, which has its sense. I mean, you must say historically there has been a big thing that capitalism has done. No? It has so dramatically revolutionized technology, brought so many changes. Look at the helter-skelter rate at which technological advancement is happening now. There's something that occurs within public health systems that will always be slow. And that's okay, because incremental is better than disruptive if you're talking of people's lives. If you say, I have an innovative thing which will be disruptive, then you're wondering whether your life is going to be disrupted, your family is going to be disrupted, what the hell is happening? I prefer incremental. But ideologically, in this language, disruptive is the big thing. Disruptive innovation. In the innovation theory, disruptive innovation is the big key. Incremental innovation is not so good. But me as a pro-people's person, I'm all incremental, never disruptive. Disruptive, the word itself upsets me. So I find that there is a thing on this. So I think this is just because of innovation theory. There's a whole lot of innovation theory. There's all this Schumpeter guys and that thing, and it makes a lot of sense. But we must be cautious about what it means for people. And
I think one of the things that makes it very hard to study, teach, and do research on health systems is that it is, by its very nature, heterodox. There is no standardized set of ideas or frameworks on which we can rely. And in fact, even each idea, for example, innovation, really draws from itself a heterodox set of ideas from different disciplines. And each of those then have become very important. So we are struggling with this as health system scholars as well. This idea of what then constitutes your sort of a spine around which we can organize our thinking. Obviously, we can always fall back on the WHO and the building blocks and so forth, but those are very limited in their. They have a certain organizations.
They are there in the past and part of a stage in our life.
But I think what you mentioned about the problem ethics, that there are specific topics that find resonance, that affect large numbers of people working in those contexts, and that find resonance across settings. Is very compelling. And in fact, even the handbook we are working on health systems in the Global South identifies about 25 to 30 big issues around which then we want to organize our thinking. So that's, really helpful from our perspective as well. And of course, the other thing that you said that was really interesting was looking beyond carrots and sticks. And I think that's another quite a big idea in itself that maybe we need to look at, because almost by default, we think about policy in terms of coercion or in terms of incentives. And what you're pushing us towards is to think about design. And I think that's, again, also contains a lot of very compelling ideas within them. So I don't know if you had any more reflections on both of those two things about push.
In one place we say carrot, sticks and sermons. Meaning also persuading people, no? So sometimes preaching, it's this notion of the public discourse. See, there's two things. One thing is to think through something that conceptually can address the problem. But the other thing is how to get it out there. If much of the problem lies in how people perceive the problem, or a particular configuration of stakeholder interests that pull in a particular direction, and there is a consensus on the stage, how do you still make the change happen? That part of it is, and how do you keep that going? It's also because this notion of a problematic means it's an eternal problem. In the sense, the problem, no sooner have you solved it, then it will give rise to another set of collaterals. So you need to have a learning adaptive system that is continuously growing on the feedback. And therefore, that has its own requirements. You need institutions that can have memory, institutions that will feed back, systems that will absorb that. So these are things that we broadly know of, but I think that's the main issue there. There are some of the, what you say, the big issues, are also some of the things that we are talking of in terms of this. So it's sort of been easy to describe it in financing because I've focused on one, but they are very difficult to solve because there are other stakeholders there. But in informatics, there's a lot of definition. But even in governance, there is a number of issues. Like you were talking earlier about these urban systems. I think we have certain issues in this, the local body versus the technical body. How do you get capacity, technical capacity in multi-sectoral areas to grow along with it? How do you absorb that learning? It's bad enough having to do it for organization or medical care. I was in Jaffna, which is a model of a healthy city. I mean, they're building a healthy city. I was talking to the sewage engineer there, and if you go to Jaffna, you can see immediately it's like any Tamil Nadu city, except it's sparklingly neat. They have managed to remove the sewage. When I talked to the engineer, he's holding his head because he says every day 60 trucks of garbage come. The garbage piles are going up. There are fires happening within the garbage. It's difficult to put out the fires in the garbage. And I don't know how to solve it. My incremental solution of separators, and this is very costly. Can you get me somebody who can put me in touch with this? He doesn't have the capacity to reach out. That whole world of thing is not available for him. So how exactly does, no sooner has there a problem than a bigger problem occurs. And it seems even more insoluble on that. So I think that's there are still general principles in that. But yeah.
Do we have any more questions, or should we wrap up?
I think here this first world, third world sometimes have a useful thing, because some of these problems have been passé in the first world. These sort of problems, where there's developed, the municipality has developed a municipal thing, whereas over there it hasn't yet happened. So there is a transfer possible if we can think of it, but that's another thing.
Well, that's one sort of big fault line in how we look at health systems. But another big fault line is also whether health systems are different from other systems. And what makes health systems so unique? Because if you say that if there are, yes, of course, there are people in charge of health systems, so they need to have an understanding of systems. But then how can we claim that these problems are unique to the health system as opposed to other social systems? And that And then, that's often used by way this sort of common sense brigade as well, as saying that, oh, these are general public administration problems. They are not, why do you need a health school to study these things? How would you respond to that?
Well, I should know about other people's problem. I know about my own. I do find number of similarities with education. But then I've talked to people in forestry, they have the same problem. So when it comes, I think some of them, like the informatics problem, is more general. But healthcare has this this high degree of uncertainty and ambiguity, which is there in this, which characterizes the clinical exchange on that. And in some sense, that is really, and also the very high degree of multisectorality. The dependence, very sharp, 70% of the difference in health outcomes between one country and another, or one province and another, can be explained more by social determinants than by the organization of medical care. You can't say that about education. Education still will depend, there's a context dependence, but it is also about schools, backgrounds, context. Here it's much more about that, and the uncertainty of that is very, very much of a problem. Yeah, but otherwise it's true. The other thing that I would say in healthcare, you have this thing called the doctor. And there's a certain professional power and privilege that doesn't flow from stature, that flows from the nature of his license to handle uncertainty, which then expands across spheres. So very often there is a difference to be made in our decision. The specialist is sort of licensed to take that clinical judgment as a substitute for final evidence. You can't extend and extrapolate it into other systems. So I think there are some specific reasons, differences, but may not be so much. And that's a reason why some of these public services don't get allowed. Because if you make it work for health, maybe across other zones of the economy, people will say, why are you allowing capitalist systems there? Why don't you go for, maybe you will end up making a case for socialism. It's a terrifying proposal prospect for some. So that if you can actually make it sure it works for healthcare, why can't I do it in education, childcare? Why can't I do it for welfare? Why can't I do it in other areas? That's socialism, and that is for many people an unacceptable goal, which is not to be confused with the old one. Today we have this whole discussion on democratic socialism, a la Mamdani and Bernie Sanders. But under that, Sri Lanka is called the Democratic Socialist Republic of Sri Lanka. They're very conscious about that. So, and they are on this phase, they are applying it across the health systems to more general lessons of public administration. So there is a meaning. Social democracies may find that quite useful to think of it that way. The reverse is true. Health system can learn from some other sectors which have done better also.
Thank you, Dr. Sundar. I think, do we have any more questions, or should we wrap up? I think we could go on if we wanted. We could. Yes, please.
Question might not be directly relevant to the topic that is being discussed. So my question is more kind of a personal question. So as you told us already, you had been a medical doctor for over 20 years. And for the past more than 20 years, you have been working in the health systems space. So I think some of us here are medical doctors. At least we have some medical background. So I just wanted to ask you, to someone who is the early stages of in the health system and policy research, what kind of advice would you give in terms of what aspects of clinical medicine have you leveraged while working in the health systems space? And in terms of that, what kind of advice would you give to someone who is transitioning from clinical practice to the health system in policy research and practice?
I mean, you do need to, I don't know. See, suppose teach you cooking, right? There are certain general rules about cooking, but then you need to know the difference between one meat and another and how you will cook. You have to know the details of what goes into the ingredient. The final food on your plate is not just the addition. If I put peas and potatoes and meat together and put it in oven, that's not a meal. It has to get cooked in a particular way. But it also means that I have to understand each ingredient in some detail. In the health systems approach, every system matters, but the relationship also matters. Every component matters, but the relationship also matters. So if you see, I run this monthly once or twice blog called Conversations Over Health Policy. And you have a bit of clinical medicine at its core and the need for innovation, new technologies where technology fails. You have access to medicines, you have public health concerns, you have preventive measures, you have things. So now the latest one is on snake bite. You have how do you prevent snake bites? Which are the countries which have done? How do you innovate better vaccines? Anti-snake venoms. How do you make them accessible? What are the problems? The systems approach actually bridges all. You do need an expertise on one thing, but that expertise alone, without its relationship to the other part, is a problem. That's one of the problems of the health systems matrix, that nowadays people have started like disease specific, they become informatics specific, or they become HR specific, or they become governance specific when it's a mix. But clinical thing matters in all of it. Now it's need not be mystified. You can actually go back and learn that. But it also needs, like pandemic prevention, there is a certain granularity there. Similarly, if a clinician enters there, he will have to respect health economics, at least. And Kabir, I wanted to say this. There's a whole discipline now called heterodox economics. There's a conference in Portugal that has just finished, International Conference on Heterodox Economics. It's come up in a big way. It is non-neoclassical economics. When you go there, you will have to learn the details. So I wouldn't put medicine on a higher pedestal than that, except it's a 5-year course, there's a lot of detail, but we don't remember most of our course. We remember certain general principles. So if there is a particular problem, I wouldn't have to study. Just like a doctor into health systems will have to study, have an understanding of economics or anthropology, and not dismiss anthropology as just common sense and behavior. You must think about it, must look and read literature on that. The reverse is also true. But if somebody has entered the field from any of the other social sciences or disciplines, he will need to respect biomedical science. So sometimes I find this caricaturization of, this is a germ theory of disease came and spoiled it all, biomedical medicine spoiled it all. I find that very disturbing, because the great founder of public health is Rudolf Virchow. Here's the famous statement that medicine is nothing but politics on a large scale, and he was an absolute founder. He was, and few people know that, one of the leaders of anthropology of his time. But in the clinical medicine world, he is known even today as the father of pathology and cellular pathology. And after Hippocrates in the 3rd century BC, he was the only next person to give a comprehensive theory of disease, which is still the ruling ground of modern biomedical medicine, rests on Virchow. So Virchow is all of these mixes. He's a socialist, a compatriot of Engels. He is a clinician, with a leading specialist in clinical medicine who has defined clinical medicine. He is also the founder of social medicine and founder of medical anthropology. So there was a unity there. That unity, now because the field is expanded, you have to come in there from some area. But one has to respect that. I find it very useful. I find that I, as a clinician, bring certain strengths to the table that nobody else can bring. It is valuable for me to be there as a clinician. But I must also respect that the anthropologist, whom we respect sort of the least within our, has also got a huge role to play. And have brought in insights that the clinician has not begun to even recognize. That mutual respect sometimes goes because the clinician places himself in a higher pedestal. That's the problem.
Thank you very much.
Okay, so I think we can wrap up, but we just wanted to thank you for coming, and also we think you've opened up a lot of ideas, and we hope we can continue to engage you in our scholarship journey moving forward on health systems. And I was so tempted to misquote Churchill, and he say that never has so little research been done on topics that affect so many people, and we really need to address that, and that's our mission as we see it. So whether that is documenting, whether that's typologizing, bringing more framing to some of these really important ideas and driving them forward. So I would say, I guess for me, the thing that I've known you for a long time, the thing that characterizes you the most for me is curiosity, and you have that unbridled curiosity, which I think we should all seek to emulate. You've also spanned different careers, and now I think you've become more of a scholar than you've been an implementer, but now you're a scholar. So we will count you among our fold, and thank you again for coming. And we'll be archiving this session, and hopefully also transcribing it, and find some ways of documenting some of the ideas that have come through, maybe as a blog or in some other form. So, thank you again, Dr. Sundar.
Yeah, we'll switch off. I don't want everything to.
Thank you for joining us.
Some of
We'll close the session now. Thank you.
Somewhere in the book I write, one of the marks of a true professional is knowing the limitations of your own profession. If I'm a really good doctor, which I think I was very